Okay, so maybe we should start. So hello everyone, welcome to Club EVMED. My name is Lucas Blumreich. I'm from the University of São Paulo and I'll be your host today. Welcome to the Club EVMED Conversations. Our goal is to connect the evolutionary medicine community and share exciting new research. So we try to have these conversations as informal as possible for discussion and the presentation of different perspectives. Club EVMED is organized by the International Society for Evolution Medicine and Public Health, and now is a great time to become a member or renew your membership. And Club EVMED is also organized by 8 evolutionary medicine centers and programs that Johnny already shared on the chat of this meeting. About our discussion, please participate in the conversation. You can post questions and perspectives in the chat box during the presentation. And you can also raise your hand virtually to ask a question anytime, and we'll call on you after the presentation. Also, feel free to tweet about this using hashtag #ClubEvMed. We are really happy for this series of talks. They are titled, "What are translated wins for evolutionary medicine and how do we achieve more of them?" And today we have Joe Alcock from the University of New Mexico presenting us with his research. So Joe has spent his clinical career practicing emergency medicine at a busy urban teaching hospitals in Albuquerque, New Mexico. He's a professor of emergency medicine at the University of New Mexico and was previously chief of the emergency medicine service at New Mexico VA healthcare system. He's also adjunct professor in the biology department at the University of New Mexico, where he taught evolutionary medicine before offering that course as a yearly elective at the UNM Medical School. Dr. Alcock discovered evolutionary medicine while a graduate student at Cornell's Department of Neurobiology and Behavior, leading to an MD in UCLA and postgraduate training in emergency medicine and clinical research at University of New Mexico. His research in evolutionary medicine is informed by 25 years of bedside experience, focusing on how microbiomes contribute to chronic diseases, whether of host responses to infection are adaptive or maladaptive, and how to confront health disparities in the emergency medicine. So thank you, Joe, for presenting us today.
Thank you, Lucas, for that generous introduction, and I'm very happy to be here. This is a topic that I enjoy getting into, and that is what are clinical trials that support or contradict expectations of evolutionary medicine. And these are the kinds of things that I talk to medical students about. So, and this gave me an opportunity to really get into some topics at greater detail. So let's start the PowerPoint here. And the title of my talk is going to be the Accidental Evolutionary Medicine Randomized Control Trial. In discussions with Cynthia Bell about this topic, we had an email exchange, and I pointed out that there really are 3 categories of randomized clinical trials that relate to evolutionary medicine. Some were designed explicitly and intentionally to test evolutionary medicine ideas, but those are relatively rare. But we'll start with that category in just a moment. But the second category are what I term evolution adjacent randomized clinical trials. These take some inspiration from evolutionary concepts. And in particular, I'll be talking about antibiotic resistance and the evolution of resistance to antimicrobials. And that has inspired a great deal of research, even though many of those papers don't necessarily mention evolution in their titles or in their content. But they are adjacent, they're nearby. And then the third category is actually my favorite, and these are the accidental evolutionary medicine randomized controlled trials. And these are based on assumptions of kind of traditional mechanistic explanations for diseases, where they identify molecular pathways and oftentimes try to manipulate those. And in many cases, the results are contrary to the expectations of the investigators. But to my mind, they tell us something interesting about the evolution of human biology as it relates to health and disease. So we'll get into that. The first randomized trial that I'll discuss is this one by Paul Young. He's an intensivist from Wellington, New Zealand. And he published this paper about the role of acetaminophen or paracetamol as an antipyretic treatment for fever in the critically ill in ICU. This was a multi-center trial with a fairly large sample. And this, I say this is an intentional trial, even though evolution isn't mentioned in the New England Journal article, but having listened to many discussions and presentations by Paul Young as he was preparing this work, it was clear that he did have evolution in mind. And so, for instance, he had an interview with the Australian ABC, and they asked him, so is bringing your temperature down important when you have a fever? And he answered no. Treating a fever seems to hinder recovery from infections. And he points out that fever has a significant metabolic cost, and it wouldn't be evolutionarily conserved unless it provided some protective benefit. And so he designed the trial, and perhaps to his surprise, when it came time to publish the results here, you can see that the Kaplan-Meier survival curves have significant overlap. So in both, there was 340 more or less in each group, one randomized to intravenous Tylenol or acetaminophen to reduce fever, and the others received placebo. And there's no difference in mortality at 28 days, and there's no difference at mortality even at 90 days. And so one might think of this as being kind of a blow to the idea that fever is protective. Paul Young doesn't necessarily see it that way. He thinks simply that there's something different about this category of patients that makes them less amenable to benefiting from fever. I think that view is also wrong, as I'll discuss. But this has not dissuaded people from using acetaminophen or antipyretics generally. Virtually every patient with an infection, and during the COVID pandemic, virtually every patient in the ICU was getting Tylenol for fever with the idea that it was good for them. So in the rationale in the New England Journal paper, Paul Young writes, acetaminophen treatment is common and is based on the rationale that fever places a physiologic stress on patients who are already seriously ill. And this remains kind of the baseline assumption for people treating fever in the intensive care unit. They think that fever is bad. This trial does not support that idea. This trial basically shows that acetaminophen in this category of patients does nothing. And usually in medicine, when something does nothing, we don't do it. But for some reason, we continue to treat patients with fever using acetaminophen. Ed Legrand, Sylvia Rotek, and I, and Arthur, wrote this paper a couple of years ago, arguing that the preponderance of the evidence, including that trial, really argued for not trying to reduce body temperature of patients with fever. We argued that the benefits outweigh the costs. And since we published this paper, or since the Paul Young paper came out, there's been some additional evidence that I want to share with you. One is this trial. This is a randomized controlled trial in which they induced hypothermia. They made patients with sepsis and serious infections lower than normal body temperature. And this trial was stopped early for harm. They stopped it before it could actually show a significant increase in death, but it was trending in that direction. And they did show a significant increase in bad outcomes. And that included patients who spent longer on the ventilator and required more blood pressure medications to maintain an adequate blood pressure. So the patients were sicker. And so this suggested that thermal management is actually important when it comes to treating patients with serious infections and sepsis, and that probably higher temperatures in general are better. And that idea is supported by this trial, and the title kind of says it all. Therapeutic hyperthermia is associated with improved survival in afebrile critically ill patients with sepsis. This was a really neat study published last year in Critical Care Medicine by Richard Hotchkiss and Ann Drury. And we'll bring up the results here. It's tiny. They only had 28 patients in the treatment arm and in the placebo arm, but they did show an increased survival in those who were warmed up. So these are patients that present with sepsis that don't have a fever. And what they showed was that if you just give them a warm air blanket where it was circulating warm air, they rapidly warm up. There we go. There's the temperature. So in the treatment group above, the temperatures were in the febrile range or near or thereabouts, and survival was significantly improved. And what I like about this paper is that they point out that there could be a constraint, a physiologic constraint in these patients that prevents them from having a fever. It seems like the their set point for temperature is higher. And if you provide the temperature, they warm up just like lizards did in Matthew Kluger's 1975 paper published in Science, showing that external heat prevents death in infected lizards. It looks like this may be similar in human patients. And so they argue that these patients probably have something where they cannot mount a fever because of cytokine insufficiency or mitochondrial problems. So we're going to change gear. Having gone from the intentional evolutionary trial to the evolutionary adjacent trial, we're going to discuss a topic which is super important and one that I bring up with my medical students all the time. And this is the idea that, in fact, we do need to worry about prescribing antibiotics. And in addition to the yes or no question to the prescription itself, we need to think about dose and duration. So this is a problem that we can date to Alexander Fleming during his Nobel Prize speech, in which he argued that there was no problem about underdosing penicillin because it's not poisonous, or no need to worry about overdosing. But he did argue that there's a danger in underdosage, that essentially bacteria could escape killing by penicillin and might become resistant as a result. But we know since his discovery of penicillin that every time a new antibiotic is discovered, a few years later, like clockwork, we see evidence of resistance. And this is because antibiotics produce a selective pressure that favors mutants that confer resistance to those antibiotics. And this is a great illustration of natural selection in medicine, and of course, one that I'm sure most of you are aware of. And this figure, that's in a paper by Clatworthy from 2007. We're gonna circle back to this later, as you'll see. I'm gonna use this as a bit of an inspiration. So antibiotic resistance resistance. This has been pointed out by such people as Brad Spellberg. He's an infectious disease doc, and he argues that we should be prescribing antibiotics for the shortest duration that we can get away with, and that the evidence supports this. And he gives a evolutionary rationale that is based on work done by some of the people in this room, by Andrew Reed and Sylvie. The idea that more selective pressure by larger doses and greater duration of antibiotics drives resistance when those genes exist in a population. So here's Reed and colleagues' work showing experimentally that if we increase the doses, we see a rapid shift from susceptible to resistant parasites in this case. So work has been inspired by this theoretic and experimentally derived observation. And it's led to a whole bunch of papers, including this one, which was published in about 7 years ago in the New England Journal. I included it just because it was published in the New England Journal. Also, it caught my attention because we think of intra-abdominal infections as being quite severe and bad. And typically clinicians like to treat those for a longer period of time. But in this case, they tested whether a 4-day course could provide benefit compared to a longer course. And they did find that there was no difference in outcomes. But evolution is not really discussed in this paper either, which is why I include this in the evolutionary adjacent category. So Spellberg has identified at least 100 papers that show that, again, we can clinically get away with using shorter courses. This is better for patients. They have less gastrointestinal upset. We don't disturb the GI the microbiome. And from a population level, if we were to adopt this in a widespread fashion, we would no doubt have a decrease in antibiotic resistance, although that remains really to be seen. And there, when we've discussed this topic in previous evolutionary medicine meetings, there was always a concern that there could be a conflict between treating an individual and treating a population with regard to concerns about resistance. These results really show there is no conflict. Patients are better off, and they have equal outcomes in terms of clearing their infection when we give them less antibiotics for a shorter duration. And this includes things like sinusitis that you might expect, but also gram-negative bacteremia, which I wouldn't necessarily have expected. So it's kind of across the board, shorter courses seem to be equally good. So that's we're moving away now from this evolutionary adjacent category to now talking about my favorite topic. And these are trials that were done that I would argue tested a concept coming from evolutionary medicine without their authors knowing it, and without really it being noticed by anybody. But of course, this is of great interest to me. So this is the accidental randomized control trial. And the one that I'm going to discuss, one of the most recent ones that came out, was a paper published last year that looked at this question of patients with severe infections and sepsis, the idea that they have a vitamin deficiency. And it turns out that if you look at observational data, patients that present with this overwhelming infection and what we call sepsis or severe sepsis, they often will have low circulating vitamin C levels. Now, we don't manufacture vitamin C in our bodies, which is why scurvy can happen if we don't get enough vitamin C in our diet. But it seems like the levels plummet during sepsis. And that is thought to, because vitamin C has both antioxidant and anti-inflammatory properties, it was thought that this deficiency in vitamin C might actually cause worse outcomes in sepsis. So that was what prompted this line of research. And you may remember there was a lot of publication, a lot of fanfare that came around this guy's work it was about, let's see, 8 years ago, 7 years ago, that in which he published a case report, actually a case series, before and after trial, in which he more or less argued that by giving people vitamin C could cure sepsis and prevent mortality. He gave vitamin C along with another vitamin, thiamine, and hydrocortisone, but the main actor he believed was vitamin C. It turns out that he was wrong. There have been, and I speculated at the time when I was giving talks about sepsis that this line of research probably was not going to be as successful as Paul Merrick hoped it would be. And that is because I adopted the antibiotic resistance timeline and put in something similar for agents that have been used to target immunotherapies for sepsis. So there's been interest since the 1960s that we can somehow engage or interfere or block various aspects of the immune system and improve outcomes with sepsis. And this comes from the idea that sepsis is a dysregulated state that involves deficiencies like in vitamin C or in steroid production. And so there have been efforts since the 1960s to change the host reaction to sepsis and see if we improve outcomes. These have invariably failed, and they have failed over and over and over again. And some of the highest impact examples of this are shown here. Many of the trials at the top were randomized control trials, but many of them single center trials. When they were done in multi-center, larger, better designed randomized control trials, all of these interventions were shown to not improve outcomes. And the same is true for vitamin C. So vitamin C, there were 3 trials, including the most recent one, that really put the nail in the coffin for vitamin C. So we don't treat patients with vitamin C when it comes to sepsis. So here's the trial, LaMontagne, published last year in New England Journal. They gave intravenous vitamin C over 4 days with the idea this is going to help patients who are supposedly deficient. And instead of finding better outcomes, they actually showed that death was increased. There were increased deaths in the vitamin C group. This is completely contrary to the expectations of the original authors, and certainly for Paul Merrick, but it joined several other trials showing no benefit. There's no benefit to giving vitamin C, which suggests that there's no actual deficiency. Paul Merrick had argued kind of famously that all sepsis patients have scurvy, and now I think we can categorically say that's not true. And the idea, just because they have low levels doesn't mean that's pathological. But again, in biomedicine, we're biased, I would say, towards seeing pathology that is not necessarily there. And I think that evolutionary medicine can provide a corrective to that viewpoint. So Alex Masters and I, in writing about cytokine storms in Evolution Medicine Public Health in 2021, we argued that one reason why these immunomodulatory treatments have failed overall is that there's a legacy of natural selection that has modified the costs and benefits of this complex system. And just throwing a wrench and blocking a process or altering one aspect of it is not going to provide a meaningful fix. And the evidence does support our viewpoint. So there's another dysregulated state for which there is some new evidence that I'm going to talk about next. And this is another accidental evolutionary randomized controlled trial. And this trial involves treating patients with high blood sugar or hyperglycemia and trying to bring that blood sugar back to normal when patients are critically ill using insulin. So this is a influential trial published in 2009. It followed, there were 3 small trials that said that by doing this, by making people's blood sugar normal when they're in the intensive care unit, you improve outcomes. But all those trials had flaws. And so this trial was designed to kind of give the final answer. It involved 6,000 patients. They were randomized to conventional glucose management, doing whatever they did before, versus giving them an intensive intensive insulin regimen to bring their glucose down to something which was more normal and closer to the normal range. And again, surprising to the investigators, kind of like the vitamin C example, they found higher mortality in the intensive insulin treatment arm. And this was the final word on this topic, really up until recently. There's some more data, which I'm going to get into here in just a moment. One is that it's been studied in children. So the previous study, the nice sugar, that showed increased mortality by making patients more normal with regard to their metabolism using insulin. The same was tried in children. This trial was stopped early for harm. And they found more infections in the children that were treated with the intensive insulin, or what they call here tight glycemia group. So in the same direction, there's a signal of harm when we attempt the strategy of trying to correct a supposed dysregulated state in children. Perhaps, luckily for us, it turns out that there's a paper that was published on this just last month. So this is from the New England Journal. And this was again done by the first group, the groups that they were convinced that there was a benefit to doing this. I mean, if the metabolism is dysregulated, well, why don't we just regulate it using insulin and make everybody normal? That it must make people better. So this group they were convinced that there was something wrong with the nice sugar trial, and that really the problem involved harm from making people hypoglycemic or lower than normal blood sugar. And that's what harmed people. So in this trial, they very carefully regulated the blood glucose and did it in a way that prevented any episodes of hypoglycemia from giving insulin, which is really a problem that we confront in clinical medicine. And they published this in September of this year, comparing the same thing. So tight glucose control, meaning more insulin, aiming for a normal blood glucose of 80 to 100 versus letting the glucose go up to 215. Now I'll tell you, in real life, we see people with glucoses much higher than this too. So everybody in both arms, they were getting some insulin. The question is how much? This trial, which I think again is kind of probably the final word on this, it shows that liberal versus tight glucose control and trying to either make things more normal or letting them be permissively hyperglycemic, we find no difference in survival. And this actually was a bigger trial than the nice sugar trial by a couple thousand. It's involved over 9,000 patients, a huge trial. People have argued that even their methodology is not going to be something which can be reproduced easily in a hospital. But what it tells us is that there's no benefit to trying to normalize blood sugar in those patients that have high glucose levels when they come into the ER, hospital, or ICU. We're still going to give we're still going to give insulin because that's what we do, and that is the standard of care. But this tells us we don't need to pay so much attention to it. And what that tells me is that the supposed dysregulated state, there's no evidence that intervening makes it any better. So perhaps whatever's going on with insulin resistance and metabolism, that may actually be an alternate route of allocating fuel in a way that does something differently, and actually may provide some host benefits, possibly, right? So, and this idea is actually old. This work, kind of coincidentally, was also published by Paul Merrick of vitamin C fame. But he wrote that stress hyperglycemia shows evidence of an evolved trait. We see it's evolutionarily conserved. We can see it in different kinds of organisms that are confronting severe challenges, and that actually when an animal is under stress, having a high blood sugar may not be a bad thing. So the previous slide I showed you showed immunotherapies. These are trials designed to correct metabolic dysfunctions, other dysfunctions, and organ failure in sepsis. And I bring this to your attention because the pattern is also very similar. up above, including intensive insulin. Intensive insulin treatment was once advocated for by the Surviving Sepsis campaign, along with a whole bunch of other interventions to normalize blood pressure, to fix heart function, to improve oxygen delivery, to make blood pressure work better and make blood vessels less likely to go into vasodilation, also to treat supposed cardiac dysfunction and renal dysfunction. All of these trials have been contradicted by later and better evidence. This remains controversial, but in my view, and what I've written about previously, there's very little evidence for pathological dysregulation in the state of sepsis, which is almost, even saying it in this group, it seems subversive to say this, but the evidence does suggest that when we try to do more to make things resemble the physiology of a healthy person, when they're septic, we don't do any good. And in some cases, we may actually harm patients. This is surprising to a lot of folks. And we might do well to take the advice of Samuel Shem. This is from his novel, The House of God. And he famously, one of the precepts or the rules of the House of God is that the delivery of good medical care is to do as much nothing as possible, which as one goes through a medical career, we see more and more evidence of this. This truism that he wrote when he was an intern or a resident in his medical training, he's now a retired psychiatrist. It seems to actually kind of hold up. And I would say it holds up for reasons that have something to do with evolution. Okay, so the penultimate trial I'm going to talk about is another accidental trial. And this is the largest women's health prevention study that was ever done. Again, involved many thousands of patients, almost 17,000 that were randomized to hormone replacement therapy. This was done in the middle 90s. And this trial has been cited as one of the greatest achievements in women's health, because before this trial, it was thought that women suffered a deficiency of estrogen, and that could be remedied by providing estrogen or estrogen plus progesterone in a way that would prevent health problems associated with menopause, and not just the symptoms of menopause. That's a separate issue. These trials were designed to ask the question, does giving hormone therapy improve chronic health conditions, things like cardiovascular disease, stroke, dementia, and osteoporosis, all of those things. So this quotation by Wolf Utian, published in 1989, gives the conventional medical approach to this. And that is that women are spending more years of their lives after menopause that places them at risk to problems due to estrogen deficiency. So again, just like we had a vitamin C deficiency in that sepsis trial, here we have an estrogen deficiency, supposedly. And the concept here is that he argues that this is a state that steadily increases a woman's risk of cardiovascular disease. So lots of people prior to the early 2000s were on lifelong estrogen and progesterone with the idea that this is going to prevent heart attacks. And that was based on some observational trials and some small randomized trials. But this large trial came up with results that surprised virtually everybody. So instead of a benefit when it came to heart disease, they showed a significant difference in the opposite direction. There was an increased risk of heart disease, stroke, deep vein thrombosis, and pulmonary embolism. And what kind of got everybody's attention was this risk of invasive breast cancer was higher in the treated group. So this is published in JAMA 2002, and the authors conclude that the risk of treatment outweigh the benefits. There is a short-term benefit when it comes to bone density, but clearly if you're on this medication for a long period of time, it seems to increase one's risk of bad cardiovascular outcomes. So here, this is a result of 4 trials that were published in the years following that all do support the idea that giving combined estrogen, progesterone, and in those patients that lack a uterus who got estrogen only, there's an increased risk of stroke. So that seems even greater than the risk of heart attacks. And the risk, which is also concerning in all patients receiving estrogen, is this risk of deep vein thrombosis and embolism to the lungs, which is doubled in the Women's Health Initiative trial. So what would we think of these results in evolutionary context? So at the same time this trial was being undertaken, Steve Ostad, in this article entitled Menopause and Evolutionary Perspective, wrote that there are evolutionarily hypotheses for menopause that see it not as a disease or a deficiency syndrome, but one which is an adaptive life history transition, which I think many of us might agree with. And he said, to demonstrate adaptive menopause, you need to show that, one, people back in the past lived long enough to accrue benefits from living after menopause, not dying in midlife, and also that they are able to provide enough care of existing children and grandchildren to compensate for the loss of personal reproduction. So he's referring here to both the mother hypothesis and the grandmother hypothesis, which I won't get into details here, but the idea is that there's an inclusive fitness benefit from providing care and allocating resources to existing offspring and grandchildren, and that provides a fitness benefit. So that would suggest that menopause evolved uniquely among primates, maybe not uniquely among animals, because killer whales also undergo something that resembles menopause. But this perspective, published after the Women's Health trial, is very much like mine. And this is from Andrew Froley, who writes that a 2-decade postmenopausal lifespan is an evolved trait, distinguishing us from other primates. It has deep evolutionary roots, and it rejects the idea that after menopause, we're going to have high rates of disease and the concept of menopause as pathology. There's one other thing I want to point out here, which is that, again, we're talking about the long-term health risks of hormone replacement therapy. Giving hormones short-term to certain people is something which is advocated by people interested in treating menopause, and that can be done safely under certain circumstances. And so what Joanne Manson, who is one of the original authors of the Women's Health Initiative paper, what she has written and since advocated for is that if we can probably treat people who are very close to menopause, the youngest women, and that they seem to have some reduced cardiovascular risk. At least they have less elevated risk. So, but he says that even this proposal didn't meet her criterion for statistical significance. So in general in science, if something's not significant, it's not something we should pay much attention to. But she does advocate that we can treat some younger women for symptomatic relief. And that, I think, actually is in line with this hypothesis, the discordance hypothesis or mismatch idea, the idea that ancestrally, women undergoing natural fertility, in which women spent more time with more cycles or more pregnancies and time spent in breastfeeding, were exposed to 10 times less lifetime estrogen, at least as proposed by S. Boyd Eaton in this quarterly review of biology paper from 1994. And I think that, taking into consideration the mismatch idea, clearly taking lifelong estrogen is a mismatch condition, which would potentially cause unintended consequences from this perspective, but it's possible that the mismatch is less so in younger women. There's great variability in estrogen exposure in young women under ordinary circumstances, and more of it clearly in women who are around menopause than women who are older. So this may explain why some younger women have less risk, possibly. Let's move on. So I think we're coming close to a close here. We'll talk about one more trial, but to label something as pathological or dysregulated or non-adaptive, I would say is as much of an evolutionary claim as calling something adaptive. So when we identify a trait or a condition like menopause, supposedly, which is either non-adaptive or pathological, and the implication is that selection never acted on the trait, or the selection has not had sufficient time to modify the trait, which is probably not the case for menopause. And a parsimonious reading of human biology is that selections acted on many disease traits, even the ones that we think are dysfunctional, in terms of modifying some of the harms and maximizing benefits if they do have complex trade-offs that are involved in host defense. And I would argue that inevitably some of these traits are going to be discovered or rediscovered to be adaptive, but we need to have the right frame. And I think evolutionary medicine provides the framing to study those possibilities. So this is kind of my bottom line. Oops, shoot. I must have taken out, anyway, I guess I omitted a slide on vitamin D, but I can just talk about that one. There's a trial, the VITAL trial, studied the concept that vitamin D is up until recently, most of us believed that almost everybody was deficient in vitamin D at a level of, for 25 hydroxy D or vitamin D3, levels of 20 nanograms per milliliter, which very few people actually meet. So it looks like in many populations, a majority of people were deemed to be deficient. And low vitamin D was also associated with all kinds of diseases like heart disease and a whole variety of other things. And it was thought that we could treat this widespread deficiency by giving people vitamin D. The VITAL study involved tens of thousands of patients over many years and showed that there was essentially no benefit to vitamin D supplementation. And the authors of that paper have since come out and said that we shouldn't be testing older adults for vitamin D levels, nor trying to supplement them if they're healthy. So that's the last example of a deficiency syndrome, which seems to be not a deficiency syndrome. And there may be something to say about the way that vitamin D is regulated that reflects the legacy of natural selection acting on that regulation. So I think with that, I'm going to open it up to any questions that people have. I know we covered a lot of ground here.
Thank you very much for the talk, Joe. It was really interesting. We have some questions in the chat, but I would like to give people the opportunity to ask them themselves. So the first one was by Joseph Stanford. Joseph, do you want to open your microphone and ask?
Yeah, sure. I just wanted, if you had some thoughts. I mean, this is a common pattern in medicine in general, to have a small trial, that single center that's really encouraging, and then to have a multi-center that refutes it.
Right.
Do you have any particular thoughts or insights as to why that happens? Is it because multiple people do trials and only the positive one gets published, or are there some systemic, what you say they have weaknesses, but do you have some common weaknesses that lead to that?
Well, I think that as you mentioned, there is a pattern that we can identify here. This has happened over and over and over again. It seems to reflect bias and confounding. That seems to be essentially the reason why these trials provide evidence that is eventually contradicted by later trials. But I think so. What I tell my students and residents when we have our journal clubs is that you simply can't trust a single center trial with that's done. It's small, and we need to be especially worried about evidence coming from observational trials for that reason, that there's a bias towards publishing positive results, results that are in the direction that are expected by the investigators. There's this desk drawer problem where many studies don't get published. So even when we do these meta-analyses of published trials, that can miss some important information. So I think that, all we have to go on really are these extremely large, multi-center, well-designed trials.
Next one was by Neil Greenspan. Would you like to comment on the modality of sepsis?
Sure. Yeah, I think the presentation on the sepsis was quite interesting. But having said that, I posted in the chat, if anyone offhand knew the mortality rate for untreated sepsis, and Cynthia replied that it's 30 to 50%, and that doesn't surprise me. So I think it isn't unreasonable to expect that if we investigate pathogenesis sufficiently, maybe we'll eventually come up with a useful treatment, because not treating doesn't seem to work all that well if you have mortality at the rate of 30 or 50%.
Right. I would tell you that it's a moving target. Sepsis has undergone a couple of definitional changes since the early 2000s. And we have certainly changed our screening processes for sepsis, in that virtually everybody that comes in with a possible fever or a vital sign change that suggests sepsis will get a lactate and some other testing. And so we cast a much bigger net. And I think that the sepsis syndrome follows a continuum. If, like menopause, if everybody died post-menopause, then yeah, selection wouldn't have the opportunity to act on that trait. If everybody dies of sepsis, then you could say something similar. But in fact, there are many people that have a mild version that don't get categorized as sepsis. And now that we're casting a broader net, our mortality rates are going down. So we pat ourselves in the back and we say, yeah, we're doing a great job with sepsis and identifying everybody that has sepsis. All we're really doing is we're increasing the denominator. So I do think that my argument is that selection has acted on some of these complex traits. It's not to say that being septic is good or that any of these things is an unalloyed benefit. It is that these reflect complex trade-offs of costs and benefits that have had a legacy of selection acting on them.
Yeah, I don't doubt that, but I said later that, you know, another possibility at the end, you listed some of the issues with these sorts of situations, and I just said that I scroll down here. My last comment.
Yeah, thank you for that. And I'll take a look at that.
The conflicting forces of selection may not achieve ideal adaptation across all genotypes. I think that's inevitable.
Oh, I think that's certainly true.
So
Agreed.
for those people with those genotypes, we may not have a treatment at present that would be useful, but it may be plausible that such a treatment could be arrived at. Thanks.
Right. And I'm looking through the chat. I see lots of good stuff here. And I see that John Pepper's also had his hand up for a while.
The next one is by Robert Schottler.
Okay.
Well, do we want to have maybe John Pepper, maybe if he wants to speak? Sorry to interrupt there, but he's had his hand up for a while.
It's been a while, yeah.
Thank you. Can you hear me? I'm not sure about my microphone.
Sure.
Okay. Hi, Joe. I haven't seen you in a while.
Hi.
I loved your talk. Obviously, you're preaching to the choir with me, and I think you're spot on with everything. So all I can think about is all the ways to extend this story. And one I'm currently fascinated with is the idea that a lot of these mistaken cures for mistaken problems involve basic forms of human phenotypic plasticity. There have been different ways that humans contribute, and to the extent that we've evolved different phenotypes. And one of the clues to me is one of them is so many links to ultraviolet light. So people who are deprived of ultraviolet light have a lot of altered phenotypes that are interpreted as deficiencies or failures. They have people who are deprived of ultraviolet light have myopia, so they're still good at close-up work, but not good at maybe not so good at seeing things that are far away. People who don't experience UV light have less energy allocated to immune system and wound healing. People who are not exposed to UV because of vitamin D deficiency have lighter, weaker bones and less maintenance, less cost of carrying around heavy bones. In other words,
I guess to summarize what you're saying, I think that you're pointing towards the discordance or mismatch idea. And there's a lot to be said for that.
There have always been humans who contributed importantly by being outdoors, and there have always been humans that contributed in important ways by being inside the cave, inside the whatever it is. And those people who don't get UV light, but they contribute to the family. They do close-up work. They don't need big, heavy bones, extreme investment in immune system and wound healing. They're in a safe environment. They have a whole suite of adaptations to inside life, which are interpreted as problems and deficiencies.
Right. I think your comment about phenotypic plasticity and the fact that we have conditionally adaptive traits that respond to environmental inputs is also well taken. I guess we can go to the next question.
Sure. Thanks.
How about Melanie?
Sure. Hi, Joe. Nice to see you. And thank you for this overview. I have a question and comment that kind of going off of what Neil had said. It seems to me, one of the strengths of evolutionary medicine is that we're looking at biology and trying to devise hypotheses kind of more from a priori principles than clinical medicine might go from epidemiology and trial and error. And so the emphasis there on, looking at mismatch, and looking at what is pathology, I think is important. But at the same time, how do you balance that with not falling into any type of naturalistic fallacy where, anything that, just not doing anything and letting our bodies figure it out is good, where there's some type of balance of where we can improve. And I think, right, even with fever, isn't part of the understanding now, I'm not a physician, that low-grade fever is beneficial, but if it reaches some point, right, it's not doing anything anymore to protect the body against increased viral bacterial infection, and it's very harmful. It can be very harmful, especially in, immunocompromised or like infants and young children.
So the question about, so I agree. I don't advocate for doing nothing. I think that we need to pay attention though to negative results and not brush them under the rug. And there's lots of examples where we think that by intervening we make people better, and that seems to not be the case in a wide variety of cases. And I think that has to do with this over ascription of pathology to a whole bunch of different things, probably including fever. If you have an infection, there's very little evidence that, again, on a population basis, that reducing temperature is going to make it better. And almost, in some of these trials, they did aggressively cool people that were above 39.5 degrees C. But I would argue that even the evidence for doing that is just non-existent. It's not really based on any data. So I'm definitely a permissive hyperthermia advocate for most patients who come in with if they have an infection, for sure. Of course, we do worry about febrile seizures, but even as I wrote about with Ed Legrand in our fever paper, we argue that concern is probably overblown.
Thanks.
Yeah.
I wonder, maybe we should shift a couple to the chat and then back to hands. Would that be fair?
Okay.
Yeah, Lucas,
Great.
you can, if you have, the next one. Cool. I'll leave you to pick them.
Okay, just follow with the next one. It was by Robert Schottler.
Okay.
Yeah, I was wondering if you had looked into, well, I like what you had said about doing nothing as much as possible, and I also feel that often we address issues by looking at a pathway and blocking a certain arm of it, and we know what that does, but we don't know the unintended consequences. And so, for example, with statins and cholesterol, what is that doing to our cell structure or the Schwann cells? But have you looked into that at all? With
Am I looking into statins?
Yeah.
Not enough to make any, and certainly none of this is medical advice. I would, we have HMG-CoA reductase enzyme for a reason. I would say that it's certainly something that evolved, and we need to be careful about blocking things willy-nilly. But statins do seem to save lives when it comes to people that are at risk for heart attacks, and certainly people who have had a heart attack or a stroke. I think that this whole idea about lipoproteins is an interesting one, and I don't think that we know the whole story. And in general, because we tend to just focus so much on pathways that are involved in disease, we spend less time thinking about pathways that are involved in host protection during infection, or negotiating the trade-offs in life history and that sort of thing. So I would just say that it's understudied. But thank you for that.
Thank you.
No, wrote a really interesting question in the chat. If you would like to ask it.
Yeah, Joe, thanks very much for an interesting talk. I was just struck and interested by the vitamin C correlation because it sort of tied in, I think, to the old Linus Pauling idea that vitamin C in massive doses was great because it was an antioxidant, sort of sopped up free radicals. And that's a reasonable idea. And I could see where the trial that you mentioned would have worked if that idea was correct. But do you have any ideas about since it didn't work, there must be something wrong with the idea and Paulus's idea as well. My thought was, and you mentioned the fact that we lost the GLO gene, lactose oxidase gene, years ago, and anthropoid primates don't have that. Would an approach evolutionarily be to investigate further why or what adaptive advantages there were to losing that gene?
Yeah, I think genome-wide association studies and looking at polymorphisms is one way to kind of interrogate the adaptiveness or maladaptiveness of a given trait. I think that only gets you so far. For some things are kind of universal. When it, like, vitamin C does have this antioxidant activity, and yet when we become septic, our body does shift to be more in the pro-oxidative state. We produce, superoxide because of activated macrophages, and that's involved in host defense. So I would just say that we tend to identify some things as just being bad. We dichotomize a variety of events that happen in our bodies. This includes oxidative stress. We look at that as an unalloyed bad thing. I would say that we should be more humble in how we approach a lot of these physiologic events and say, well, when is it useful to actually have a more pro-oxidative state? And sepsis may be one of those states. Cancer may be another. Who knows? But at any rate, giving vitamin C, at least in that context, did not work. And I think that raises questions. So it generates hypotheses.
Yeah.
Maybe we can go back to raised hands. David Kennedy.
Yeah, so that was terrific. I think you make a really great argument that sometimes the things that we think of as dysregulation are actually adaptive responses, right? And the flip side of that you make is that like the dysregulation could be bad or dysregulation could just be good. But I think there's an extension of that, which I'm not necessarily saying is right, but sometimes could it be possible that we need more dysregulation, right? You showed the case of hyperthermia, showing that induced hyperthermia can be beneficial. Has there been any look into these other dysregulations or things that were thought to be dysregulations and whether exacerbating them could actually be beneficial for patients? Higher blood sugar, things that you would normally think of as crazy ideas, right?
Yeah, I think if we can identify constraints, maybe if someone is nutritionally deficient in just calories, they may have a harder time being hyperglycemic. You could imagine something like that. If some of these traits are conditionally beneficial or they involve complex trade-offs, there may be, with some careful patient selection, events where, if we go in the opposite direction, that may actually help people. And this is actually true in sepsis. For years and years, we've thought that there's excessive inflammation and cytokine storm in sepsis, even though therapies based on that idea have not worked. Now we worry about immune paralysis, and then there's some studies that are actually looking at pushing things in the opposite direction. And there may be a select group of patients who benefit from that, or may benefit from having a lower blood pressure under certain circumstances. We love in clinical medicine and in the ICU to normalize physiology, and we're pretty good at it. We're able to do it, but yet it doesn't seem to produce the outcomes that we would like to see. So I think that, yes, I think the message is we need to actually be more creative in how we think about these things and maybe test some of the opposing ideas under certain circumstances, like the temperature example.
So I think we have time for one or two questions. Alonso.
Sure.
Can I talk?
Yes.
Hearing me?
Yep.
But what you're talking about is heterostasis. And the slavish obedience we have to homeostasis needs to be revised.
Oh, I totally agree.
Heterostasis agrees with runny nose, and so we developed antihistamines and decongestants to stop the runny nose. Long-headed.
Right.
Area is the defensive washing of the GI tract. We developed lots of drugs to stop that. We need to pay attention to our defenses. Way back at the beginning, when Leeds and Nash wrote their book, Why We Get Sick, New Science of Darwinian in Medicine, which you didn't mention, and really everybody should read. So that is talking about a fever. I share your problem with permissive hetero hypothermia. I took care of a young child in my emergency room, had a high fever, but nothing was wrong with him. He was consolable. He was drinking. His blood work was normal. And, George Williams and NASA studies showing how treating it with drugs made him worse. And after I finished that, the nurse walked in with a meditated dose of ibuprofen. I didn't get invited back.
Oh. I think your comment about homeostasis being sort of the driving, organizing idea in medicine and physiology is one which is ripe for a challenge coming from evolutionary medicine. And I've toyed around with the idea of writing that book, and I have some collaborators where we challenge the idea of normal. What is normal in medicine? So I think that's those are excellent points. When it comes to fever, you know, I was going to say I always ask nurses or residents and trainees, did the patient ask for the antipyretic? And if they did, I'm fine with giving it, but I'm not going to give it just to treat a number or treat a nurse's concern.
Common Sense is my book. It's available at Amazon.
Say that again, or put it in the chat so I can. You're kind of breaking up.
Yeah, it's hard to hear you. Sorry, Alonzo.
But let's put that in the chat. Not enough time. If I maybe have time for one more question, maybe.
Yeah, do we have time for one more quick 30-second question, if that's possible?
James Gurney, did you have something?
Yeah, I was gonna say James.
I can come back in. I wasn't sure we can have another question. So, Joe, nice to see you again. How you doing? You asked. You said something along the lines of not making a statement about adaptation is effectively the same as making a statement about adaptation. How would you come back with the argument that that's equivalent to saying not collecting stamps as a hobby? You're making a non-negative statement.
Well, I mean, if you claim that something is pathological, there's an implication that it's maladaptive. If we're talking about some body's response to either an infection or some other challenge, and I think that you're making an implied argument that selection has not acted on that trait or not had time to act on it. It's an assertion. I'm putting it out there to be mildly provocative.
I like it.
I'm glad you like it, but it probably needs to be fleshed out a bit more.
Okay, I think we are going to have to wrap it up. We are at 1 o'clock. I want to say thank you so much to Joe again. That was really wonderful, awesome. You're a seasoned vet at Club F Men now. That was your second one. So thank you so much. And thank you, Lucas, for introducing and moderating and also representing one of our newer groups along with Kiel University down in Sao Paulo, the Brazilian Evolutionary Medicine and Study Group. So thank you so much for that. And Joel, I hope it's okay. I put your email in there if anyone has questions to send you any unanswered questions they might have.
Oh, that's great. Yeah.
Cool.
So it's
and I will upload this talk and the link will go on. Yeah.
Thanks so much.
Thank you so much, everyone. And tune in 2 weeks. We'll have Dr. Jacques Papin. Sorry, next week, next Friday. Jacques Papin will be talking about colonialism, HIV, emergence of HIV and AIDS.